Should I keep? Okay. Assalamu alaikum. Good morning, everyone, and welcome back to our third day of our International Dental Meeting. My name is Dr. Dina Sharif, a faculty in Riyadh Al University. So I'm honored to introduce our chairpersons for this morning, Prof. Hanan Balto. She's a professor and consultant of endodontics. She's also the Dean of College of Dentistry at Princess Noor University. And also, I'd like to welcome Dr. Ali Al-Ahadib. He's an assistant professor and consultant of periodontics. He's the chairman of dental services at National Guard Healthcare Fair. He's also the Dean College of Dentistry at King Saud bin Abdulaziz University for Health Sciences. Welcome them, please.
المرسلين سيدنا محمد وعلى آله وصحبه أجمعين. I'm so honored to be here sharing the first scientific session of the 11th Riyadh International Dental Meeting and second Saudi Dental Education Conference. Without further ado, I'd like to introduce the first speaker for this session, Dr. Huda Abdellatif. Dr. Huda Abdellatif got her bachelor degree from University of Alexandria and got her Master of Public Health and Doctor of Public Health Oral Epidemiology from University of Michigan. She got a certificate in evidence-based dentistry from Oxford University in 2009, and currently she's a consultant and the head of the Community Service Unit in College of Dentistry, Princess Noor University. Today, she's going to present a topic entitled Dental Education's Role in Igniting Community and Social Responsibility. Please welcome with me Dr. Huda.
Bismillah ar-Rahman ar-Rahim. Thanks for introduction, Dr. Hanan. Before starting my introduction, I'd like to talk about two stories of two my dental students. They're not a student anymore. I will talk about Sarah and Nancy. Sarah, she was a very bright student. She graduated at the top of her class. After graduation, she went to graduate study. Then she worked with one of the practice. After well-known practice, she did, 2 years after that, she has her own practice. I get a chance to see her in one of the conference. She was telling me about her success in the private practice and how happy she is. I can say, I'm proud to be able to say that Sarah is one of my students. Another student, which is Nancy, another bright, excellent student. She graduated not at the top of class, but as a very good. After graduation, she didn't go to any graduate study, but she decided to go and practice. And she decided to join the Doctor, Without Border. She went to Benin, and when she went to Benin, which is, as you know, it's the west coast of sub-Sahara Africa, and she worked there, addressing dental problem. I like to think of them, of a success story when I'm going to social responsibility and looking at them as successful. But I like to start them with their story as I'm going to talk about the dental education role and igniting community and social responsibility. So today, we're going to talk about what is social responsibility, its element, and importance and need of social responsibility, what we have as evidence, and the module in integrating social responsibility in the dental school curriculum. And mainly, this presentation is food for thought, that's to encourage some critical reflections. Social responsibility, just take a second, and just reflect and think about it. How would you find social responsibility? What is a social responsibility? If you think about it, I would say that social responsibility is one's duty or sense of duty to contribute, to the society which one we live. We can also think about it that it is how to make sure the ensuring, protecting, and contributing in the welfare of that community. And when I talk about contributions, this contribution has to come by choice. It's not a forced contribution. It's not by being legislated to do it. So, looking about that, 2 days ago, Dr. Karen was discussing and presenting ethics and professionalism. Today I'm going to talking, the topic is a little bit related, but a little bit, again, difference. So ethics, we know, belief about right and wrong, and as we just define social responsibility, it is the obligation to contribute to society. So we can thinking about social responsibility as an ethic framework that an entity, whatever is the organizations or individual, that has an obligation to act to the benefit, for the benefits of the society. And if you think about it as our professional, I can say that it is ethic of social responsibility, that to respond to the burden of disease and to make sure that each individual in our society had ability to access to care. So if you're thinking about it, social responsibility is the ethic of caring. You care. If we decided that this is the definition, let's talk about it. What are the ingredients? What are the elements that make individual a social responsible? So let's looking about that, making it. So one element, I would see, as you see it here, one of the first element is to be able to transmit appropriate value. So a social responsive individual need to be in a position to transmit. And if you're thinking about ourselves as a dentist, I think that we are, when we are interacting with our patients or interacting with each other, the society provides us the status, that position, that we can transmit value. Another element that in the social responsibility is to have the skill and the experience and understanding to exercise such responsibility. So we move from positions now to move toward action and doing it. And then the third one, we're talking about an individual who care. He care about the community. And this is by caring, he has or she has the conviction in her heart the importance to contribute. So something within yourself. So this is just, I would say element that how an individual to be a social responsible. Then I would like to go and talk about social responsibility framework. This is a little bit theoretical, but for the useful, for the developing of my talk, I'm trying to set some sort of a framework. So if I talk about it and you just think about it for a second, what is our word? Can you define what is your word? Our word, we live in it. What it is? Okay, we can thinking about it. We are bunch of human. Bunch of human are living, in that world, and we interact with each other. That we are not only by ourselves. There is other human that live somewhere, and this is what we call it, the social world. Okay, sorry, the social world. Okay, in addition to social world, we look to the environment. We live in an environment, and this environment is what? Is the ground, the air, the water, the trees, the animals, and this environment sustains us. Although this is not my talk today, I think it's also our responsibility to promote environmental responsibility. Okay, as I say, I'm going to talk about social responsibility, but again, there is environmental responsibility. Then the third one, which is the economics. And economics has another theoretical disciplines. And when I talk about economic, I'm not talking about money. I'm not talking about financials. Economic is the interactions between individuals and the benefits coming up from that interactions. Okay? So what does drive us to buy certain good? What drive us to what drive us to interact or to spend some time? And this is always, there is an economic, which is the benefit of such interaction. And if you remember the movie Beautiful Minds and John Nash, he talked about that concept, the benefits coming out of an interaction. It doesn't have to be necessary financials. So looking to that, this is as a framework. Now to move to another, how do we perform? There is a spectrum. And how do we perform within that spectrum? So from this, as you can see, there is a level of social responsibility. If you're thinking from the completely left, there is no obligation, there is no recognition that you are to have to be obliged to do any contribution in the society. And from the right one, that there is a proactive contributions from that individual, that they introduce it and integrate social responsibility in all the parts of her life or his life. And I like to go back to the story that I talked about it, Sarah and Nancy. So where do you put Sarah and Nancy? Although there are, both of them are successful individuals, but I can put Sarah in the less responsible individual. She's only focused on her career, of success of her career. But if you look to Nancy, that she went out and worked in the Sub-Sahara Africa, the West Coast of Sahara, this is more socially responsible. So again, take a minute or a second and think about yourself, how you define it yourself as a social responsible in that spectrums. Then, you know, we talked about the framework, social responsibility, and when I'm talking about it, we talk about the practice dentist. And we ask ourselves, is the practice dentist social responsible? And I can see from this audience, some are our educators, some are practicing dentists, some of them are students, but I like to go to the educators, and some of them both, educator as well as practice dentists, but I wanted to relate to that part of educators and think you and your relations with the dentist, with your dental students, and the part that you are doing in education, educating that future dentists. And I believe and I think we as educators, we are supposed to be more responsible, socially responsible, than those who are working in the mouths of others, which is a practice dentist. Why we think that? I would say we are, you know, social responsibility at the top layer, because we need to ensure that we promote social responsibility among our students, and to ensure that, and if we are not teaching them social responsibility, I believe we are failing and we are consider ourselves social irresponsible. So the question is, are we creating social responsible dental professionals? You know, there is, you know, we have to be fair, this is, you know, relatively new concept. However, that it's, you know, some of the schools are addressing and understanding the importance of social responsibility, are trying to including in their curriculum. WHO put it on its radar in 1995 and stated that social responsibility for health professional school as the obligation to direct the health professional education, research, service activity toward addressing the priority concern of the community, the region, and the nation health profession have a mandate to serve. So in order to be fair with that, there is schools, I will ask the questions, and how are our dental curriculum doing today, and what are the evidence? And before going into that, I like to see a show of hands. If you have been introduced to the topic during your educational training, dental education training. Did anyone, for myself, I haven't been introduced to that. Just a few years ago, It's not too many years ago, but just a few years ago, I don't think I get the training or any topic regardless social responsibility. And I see from the class, even the young as well as the relative young that we are not introducing that topic. So how are we dental curriculum are doing today? Again, as I say, it should be fair that schools in the States, schools in the Europe has been introducing, because it is a competency now. It is a competency that students have to be social responsibility and engage in the community. And if you look to the mission and vision of many schools, they have it in their mission or in their vision. The question is, are we addressing it, or it's just there as a mission? So I am going to go through some examples that is done in the state related to social responsibility. So they're talking about, it's a study, I'm going through the evidence about it, like here, one of the evidence of Hayden and Dahami saying that there is no emphasis on social role and responsibility in the dentist, and ethical and sense are not promoted, social responsibility. Other states saying that the training modality to achieve the competency, as we just said, is not clearly defined, and the outcome are elusive, measurement of outcome. Other studies showing, again, if you're looking to the perception of the students, then there is no agreement that there is not promoted, as also they have an argument which are supposed to be responsible. Is the dentist, the dental professional, and they have that argument in my class. No, it is the responsibility of the government. The students come to the dental school with certain expectation, the expectation to have the clinical skill. They wanted the curriculum to be focused on a clinical skill, and also they say that many students thought that their interest is of going to school is also motivated to provide care, but it is motivated to earn high income. Okay, they talk about the influence of the faculty into the value that they have, especially in the final year. Darhami say that the economic part affected about how dental education is practiced. So if you talk about that, social responsibility, and how is the dental school roles in it and promoting social responsible individual, I believe that the curriculum should be, build experience and desire for the future dentist to be continuing engaging with his or her community, and we need to develop a foundation to provide that goal. Here it is. I'm going to talk about certain modules. I'm going to get a little bit fast because I know the timing. A module that is in the United States, PNU, and North Carolina and British Columbia in the scope, and this is the level of intensity that the social responsibility is integrating it. So in this one, it is done for the preclinical, and there is two teaching methods. They have the community service learning. I'm not talking about it because Dean Karen talked about it, and the roles of reflections. And In this one, the students do 40 hours of non-dental related community service for 2 years, and they need to reflect about the success, the challenge that and rethink, reconstruct about their project. Okay? So they promote the spirit of services. In PNU models, and I think in all the models, I believe in the dental school in Saudi Arabia, it is that we introduce the social responsibility at the in the D5, and usually it is focused on educational, just project that they do educational community project and having poster presentations. In the model of the DISC in the University of North Carolina, here that is the graduates are going and have summer rotation. They provide really services, and they have to do 4 weeks of contacting needed populations in the community and provide services from examinations, cares providing, as well as educations. And then again, they have to go and reflect about the challenge, and by the reflection, it does stimulate them and ignite them the sense of the social responsibility. Another very intense one was the PACS. The PACS in the university, and it's a curriculum that's starting from D1 to D4 and involve understanding the community issue and introduce them about their role as social responsible member in the community. So as you can see here, from year 1, 2, and 3, and 4, there is always part of social responsibility that it is integrating in that. Another model, which is completely, and some of you perhaps know it, in Arizona, which is the community-based curriculum. One should keep in mind that those we have to ensure that there is an evaluation and see the impact of long term, and we can show that social irresponsibility can also not be, although we provide them with the curriculum of social responsibility, we're going to find some are not responsible. Again, what is the next of our dental curriculum? And I say this is how can we introduce it? That we wanted to have a curriculum, that it is innovative, collaborative with other partners in the community, participating, all the members, and transforming the individuals. Thanks. And if any questions, I just say that is just, try to simulate some thought about the importance of social responsibility among our dental students.
Thank you so much, Dr. Huda Abdel Latif. Now we'll open the door for the discussion. Yes.
Thank you, Dr. Huda, for that very informative presentation about social responsibility. And I wanted to ask regarding social responsibility and the publication of that. There's a very fine line between marketing your social responsibility because you want to increase your income or increase your visibility, versus what we have in our Islamic faith as doing social responsibility without publicizing it. So how do you see that role?
I think what you're doing is just when you social responsibility, it's important that you're doing because it's a sense of duty and not really going because of the marketing. But at the same time, زي ربنا سبحانه وتعالى تديها في الخفة أو sow it to stimulate others to do it, to promote this culture, because it's a culture. And if everybody doing the same cultures, this is really you addressing the problems in your community. So you wanted to engage everyone. So, and then there is taban, as we say in the spectrum, there is more responsible and there is a level of responsibility. Yes.
Thank you
Yes.
very much, Hoda. One of the things that we have noticed in the States is that in the university level, when students come in, they come in with a high level of social responsibility, but when they graduate, it has been found to be diminished because of all of the work that they're doing during the 4 years. Has there been any studies, or do you plan to do any studies with dental education regarding from the beginning to the end of the curriculum?
I don't know about that education, as I say that we need to assess it, but in case of the models of the social responsibility in United States, you're right about that, because social responsibility, it is, embedded in from their elementary school, from kindergarten. They have to be social responsibility. And you're right, when they move to the dental school in the state, because of the pressures and the challenge that they receive. Now there is, we should do conducting some social responsibilities research addressing that.
If you allow me, my name is Nabil Sudmi, and I'm from John Hopkins Ramco Healthcare. It's not a question, but it's more of a comment. I think the examples that you presented for Nancy and Sarah, it's the extreme and the spectrum. But a point of fairness, when we were in training under the leadership of our colleagues and faculty, we were introduced to social responsibility by going and visiting dental schools and educating, and that concept was introduced to us as young. And now, as we become leaders in our organizations, I think that seed that was presented into us, we carried out into other community outreach programs. And not only that, it's also introducing students to come into our organizations and having some role of education. I just don't want to be confusing our dental students that if you become like Nancy, you'll be totally socially responsible. We can always contribute whatever we are in our daily work. But thank you very much. It's an important topic.
As I said, that you have to think about it, how are you doing as a social responsibility? That is extreme, but social responsibility is contributing, and there is a continuity in it. And this is what the things that if they don't have a continuity of the social responsibility, and you do it once and once, and that's you stop, you're not social responsible.
Thank you, Dr. Hoda. We in this college here and this university is an integral part of our curriculum, actually, as you know. Yeah, I was impressed by the special different packages we show from the United States, but actually it's integrated here. And you know, the social responsibility comes in different ways, implied and structured. Our students here have to go out in their community program. They have to go to malls, they have to go to schools, they have to go to primary care centers, and I think we do that. And also, we teach it. We teach by starting with patients. The patient is in the chair from outside, didn't leave the house to come and socialize, talk to you for nothing, came for a reason. So in our college, in our university here, it is an integral part of the curriculum. I don't know whether we are meeting all the goals.
I want to just respond to you. There is, I agree in here and in PNU and other, but you're doing it as educational. And social responsibility, as I said in my beginning of it, it's a skill. It's not just to provide awareness. Awareness is not enough. And I agree, private practice do treat a sick individual. But if you're doing something above and you're going to the health disparity, the burdens of the disease, the one who are vulnerable, you go out, you don't, and not only just the mall, just education. But you go and provide the services, as he said, outreach, and this is social. And you want it to, in every program that we are conducting, let's see the impact of what we're doing. 10 years from now, on our students? Are they continuing that social responsibility, or they just go back to the
Okay, we'll take the last question from here.
Thank you, Dr. Huda. So as you know, most universities in the U.S. started to have dual program, the DFS program with the MPH program. How important do you think this step, and do you see it as the future of Saudi dental education? If you give us your own perspective.
Can you repeat your question?
Like you have MPH program and BDS program, like in the undergraduate.
MPH, I agree with you. I can see
Because
the public house. There is a public house, and
Right.
you can see that I'm coming from public house.
Right.
And public house have that social responsibility.
How important
And
do
I
you see
think
this
Dr.
step?
Professor Abdullah, he was trying to do that with Arizona to have a joint program, and to have DDS as well as public health. And then this, if you have that type of curriculum, definitely you're having more students will be more engaged.
Thank you so much, Dr. Huda, for your informative presentations. And in behalf of the Scientific Committee, we'd like to present this certificate as an appreciation for your participation.
Thank you, Dr. Huda, for the informative presentation. And I'll be honored to present the next speaker, Professor Fuad Salama, who's also I'm honored to be one of his students one day, and I'm still learning from him. Professor Fuad Salama is a professor of pediatric dentistry, King Saud University, College of Dentistry. He completed a Master of Science degree in oral biology and a certificate of pediatric dentistry from the Medical College of Georgia School of Dentistry. He is board certified by the American Board of Pediatric Dentistry and Life Fellow of the American Academy of Pediatric Dentistry, the American College of Dentists, and the International College of Dentists, and also the Academy of Dentistry International. Dr. Salama has won numerous awards and holds positions of responsibility at the national and international levels. He served as a member of the American Board of Pediatric Dentistry Examination Committee and editorial board of the Pediatric Dentistry Journal, and a reviewer for manuscripts of the Journal of the Dental Education, Ed Portal, and General Dentistry Journal. Also, he served as a member of the Commission on Dental Accreditation. Also, Dr. Salama had published over 90 publications and presented more than 150 abstracts and table clinics. Dr. Salama's topic today is interprofessional education, overview and implication of infant oral health for healthcare professionals. Please join me to welcome Dr. Salama. Thank you.
Thank you, Mr. Chairman, for the nice presentation. You make me feel like a very old guy now, with you being my student. It's a great pleasure to be here today. And Bismillah ar-Rahman ar-Rahim, wa salatu wa salamu ala Sayyidina Muhammad wa ala alihi wa sahbihi ajma'in. I would like first to thank the President and members of the 11th Riyadh International Dental Meeting and the second annual Saudi Dental Education Society Conference for having an awesome conference, excellent speakers, great workshops. And as you can see, the theme of this conference is aligning dental education with best clinical practice. This theme is related to my presentation, which is titled Interprofessional Education Overview and Implication of the Infant Oral Health for Healthcare Professionals. The purpose of my presentation is to give an overview of the interprofessional education and implications of infant oral health for healthcare professionals and implication of educational intervention programs involving training of different healthcare professionals about infant oral health. This topic and what it includes, it is related indirectly to dental cares. The term interprofessional education is now more and more commonly used, and you hear it in different presentation or different curriculum and so on. And interprofessional education occurs when two or more professions or students learn about, from, and with each other to enable effective collaboration and improve health outcomes. It is a lifelong approach to education which should begin in undergraduate courses. Another related area is interprofessional collaboration and interprofessional practice, which occur when multiple health workers from different professional backgrounds provide comprehensive health services by working with patients, their families, and communities to deliver a higher quality of care across settings. So now we are talking about working with patients, families, and communities. In general, interprofessional education will result in collaborative, practice-ready health workforce, which in turn will result in collaborative practice with the end results of optimal health services to our customers, to our patients. Competencies, you heard this as a students, curriculum, everything now has its own competencies. And also interprofessional education has 4 core competencies, which is the values, ethics, role responsibilities, interprofessional communication, and teams and teamwork. The framework for action on interprofessional education and collaborative practice recognize that many health systems throughout the world are fragmented and struggling to manage unmet health needs. For us as a dentist, or dental profession, this unmet health needs is the dental caries, which is related again to my topic about infant oral health. Talking about prevalence of dental caries, in 2010, untreated caries in primary teeth was the 10th most prevalent condition, affecting 621 million children worldwide, which was not significantly decreased from 1990, which is really disappointing. You see, that guy is very disappointed because of that. There is no changes over almost 20 years. There is evidence that the burden of untreated caries is shifting from children to adults, with 3 peaks in prevalence at age 6, 25, and 70 years. So you guys as adults, we should worry because it's coming toward us. In the United States, the early childhood caries remains highly prevalent in poor and near poor U.S. preschool children, and the American Academy of Pediatric Dentistry promote appropriate quality oral health care for infant and children and education of health community and society about its unique challenges and management. In Saudi Arabia, prevalence of dental caries is also important to be aware of. Historically, the first national study was done on 12 to 13 years of age by Ashemari in 1999, and they reported 75 in urban and 67% in rural areas. Later in 2002, Al-Malik reported 73% in the preschooler, and more recently in 2011, Al-Ajeli reported in systematic reviews a national caries prevalence of 80% in primary and 70% of permanent teeth, which in general, considered high. American Academy of Pediatric Dentistry encourage caries risk assessment by dentists and non-dentists. As you can see, it is for physician and non-dental health care providers. So anybody can do that. It is a simple form, as you can see, that you can follow the instructions, mark certain things, and you will be able to decide if the child is a high or low caries. If we focus on only dental profession to prevent caries, that's maybe very hard. We have to get other professionals with us to help in getting, our goal of prevention of dental caries. Why? Because, as you can see, there is a shortage of 4.3 million health workers worldwide. By only dentists, it will not be possible. We have to get interprofessional and other interprofessional, individuals to work together for the same goal. Attempted to start caries prevention and interprofessional education or collaboration or practice. Where we started? We started by creating a basic training on infant oral health, and this is made for different healthcare professionals, family medicine, physician, nurses, allied health, and so on, even dental students and dentists. And the aim is to educate them to improve their knowledge about infant oral health. This training presentation included some videos, and it emphasized that the caries is transmissible disease and early intervention is critical. The training presentation include prenatal oral counseling. This prenatal oral counseling is something that we don't usually do, but it is important, especially for the newly pregnant mother. She's very excited about her new baby. She's really, ready to hear anything about her baby, that she can, keep his mouth nice and free of caries. So this kind of prevention is primary prevention, which intervention to parents allow benefits to get it by the child. We can educate them how to reduce S mutans, prevent early colonization, vertical and horizontal transmission. The vertical transmission, as you know, is transmission of the microorganisms from the mother to the child, or the horizontal from the siblings or other children in the daycare. So all this will be, part of the educational intervention. The other part is the dental home anticipatory guidance and infant oral health. This part of the dental home, it is the first visit to the dentist. We encourage everybody to know that the first visit to the dentist is by 12 months of age. Believe me, until now, even in US, when they do surveys, some dentists, they use the old textbook, and you ask them and they tell you it is by 3 years of age, which was a long time ago. So it is important to know this. What we do in the dental home. The dental home provide opportunity to implement preventive dental health habits that meets each child's unique needs and keep the child free from dental or oral disease. For example, educating them not to use a bottle. By the way, this is my oldest son. I will not tell you how old he is now, so I don't know my age. Okay, but he has no caries, so we did clean his mouth, or his mom cleaned his mouth very well. Okay, by anticipatory guidance, we do some proactive counseling of parents, and this is very important because we will be able to educate and teach parents about teething, nutrition, referrals, recall, risk habits, emergency treatment, and even regular treatment. And more important is the prevention. This is very important slide because, when we ask interprofessional, or promote interprofessional education, we should be able to educate our other professionals what to do and how to examine an infant. And this is the common position. We call it knee-to-knee position, which is the father or the mother will hold the child's hands, and the two legs is around the waist of the mother or the father. The head is on the lap of the dentist. You place a towel here before you place the head, and you can do exam. You can do a lot of, prophy, fluoride, showing the mother many things in the body, and that's very important.
Oh, very nice. You are such a good helper, my friend.
You see the knee-to-knee position?
There we go.
She's doing a toothbrush prophy.
You like to bite on the toothbrush, don't you? You silly girl.
I want you to see the toothbrush prophy. This is not very common for you to see.
You are my cutest patient today.
It's a good baby.
That?
But even if he cries, it's good because he opens their mouth.
Right. Dry your teeth off. Dry them off. Very good.
I'm surprised she's being so good because we try to wipe her mouth.
Oh yeah, she hates it.
She hates it?
Yeah. She hates it.
Oh, she's doing fabulous. And these are just those two.
Then she's now placing a fluoride
nice
varnish.
And sticky, so they're going to stick on her teeth all day long. Okay?
Okay. Do they taste good?
They taste
Painting,
like sweet
enjoying.
tarts.
Oh, she's gonna like that.
Placing the
So
fluoride.
they'll taste like sweet tarts. Tonight, I want you to use your old toothbrush that you guys have at home.
Okay.
Okay? They are pretty sticky and they will stick to the toothbrush bristles. Okay? So use your toothbrush that you have at home tonight. That's it, my friend. Good girl.
This baby, is not the usual one. His dad is a pediatric dentist. Maybe that's why he's not crying. He's not scared. But even if the child cry, he will open his mouth so you will be able to see the teeth and examine and do whatever you are intended. If you didn't hear what the doctors was saying is when you put the fluoride varnish, which is important and a good tool. In US, there is many practitioners, pediatrician, okay, not pediatric dentists. They are allowed to do that in their offices. Okay, so this is a very safe kind of fluoride that can be applied, and we are not wallowing about side effects, and that's very good. And you inform patient about not to use the toothbrush that you give him during the visit. It has this fluoride varnish stick to the teeth, and so it stick for 12 hours. We leave it without any brushing. After 12 hours, you use the toothbrush, the old toothbrush, to clean the mouth and throw it. Then you use later on the new toothbrush. What we created, we tested in different professionals, the family medicine residents, we concluded that this educational intervention was effective in educating them about infant oral health. When we asked them, would you like, how likely you are going to implement the information in your practice? 92, they are very likely to incorporate. 8%, they are somewhat incorporate. This is for pediatric medicine residents. They also reported the same. The education was effective, and 78% were very likely to use this information, and also 90% were satisfied, or 10% were somewhat satisfied. Look here, this is our dental students, is a female dental students in King Saud University in 2011. They were also having reported the effectiveness of the educational intervention. But you look at this, 65% very likely to incorporate, 33% not likely, somewhat likely to incorporate, but 2% wouldn't incorporate. You may be surprised, but we as a pediatric dentist, we are not surprised, because we see that on a daily basis. Some of our undergraduate students will avoid, they don't like to treat children. And they wait until they become interns, and they try to avoid, scheduling children with them. So it is a fact, okay? The pediatric medicine, you remember, pediatrician also, pediatric residents, and pediatric medicine residents, they will never do that, but our undergraduates, they will do that. We did a similar study in 2017 in the same college, female dental college, but at this time, the students, they created their educational intervention. They didn't use the one we have it before. And again, the results were like 65% very likely to incorporate, and 28 somewhat, and about 5% will not incorporate. We did this study also in 2013. It included the freshman dental students in Prince Noura University. And they were also effective, although they were only the freshmen. And 95% reported the presentation was helpful in improving their understanding of infant oral health, and 67% they were very likely to use the information. I put these couple of slides because I want to tell you that, having a general dentist, which originally, undergraduate, they are not always like to treat children. This study, we did it in Nebraska, state of Nebraska in US, and when we asked the general dentist, how often do you see patients less than 23 months of age, we found that 29% they don't see children. So 1/3 of the surveyed general dentists, they don't see children. Why? This is what they reported. They reported, so many reasons. But the four most common were not adequately trained, not comfortable, refer to pediatric dentists, and most do not need care. Actually, all this can be easily overcome by educating the general dentist, because this is important for them, at least to have initial exam. If there is a difficult child, they can refer, but not, from the beginning. General dentist, 50% of them, they don't do prenatal counseling. That means 50%, do not do it. And the most common reason for not doing the prenatal counseling is it's not important for the office, and also parents are not interested. We did this with the parents, and their knowledge improved, and 80% reported that they improved their knowledge. I put these slides because King Salman Center for Children Health is a very good center. And it could be the center where all other interprofessional or professionals of different specialty or different fields will be part of it, to distribute and to make a plan for future, use of interprofessional education throughout the kingdom. In summary, our aim is to have a new generation of dentists with a paradigm shift in training and thinking about caries prevention in the 21st century. A roadmap with clear starting target, tactics, approach, and destination is urgently needed to improve oral health of Saudi Arabian children. Have medical approach to dental caries and fight the disease, not the caries. And the final slides is preventing early childhood will include a lot of puzzling parts: prevention, interprofessional education practice, joining forces, and the last one is the missing link. And the missing link is follow-up. Everything you do needs a follow-up. You will be able to evaluate, you will be able to improve, modify, revise, and that's where we should do what we should do. With this, I would like to thank all of you for listening to my presentation, and I will be more than happy to answer any questions. or to have any feedback. Thank you.
Thank you, Prof. Fuad, for this nice and informative presentation. We'll open the floor for one or two questions. Okay, since no more questions, so on behalf of Prof. Shamiri.
Good morning. Thank you, Professor Fuad, for this.
Thank you.
Again and again, because I listened for this presentation many times, but every time try to update it, I think, with a different approach. Since you are, among those leader, in the prevention pediatric dentistry, with your experience again so long at King Saud University before and later, did you realize there is any change now from the way? Did you realize there is any changes now among the dental practitioner within our society when you approach your previous former students, colleagues, about application, a lot of this prevention within the pediatric clinics? Not with the specialists, I talk about general dentists, how they practice,
Yes.
Because I saw your study in Nebraska. I wish you present something for us in Saudi Arabia, due to your leadership and the way, the one which you published it, 2010, about once every week.
Yes.
Yeah. How this, match within our Saudi society here?
No, to answer the questions, honestly, I don't see so many changes. And one of my slides, when I showed over 20 years and worldwide, there was no change in the prevalence. So it is, I believe, our approach is not focused on the proper way to prevent. I was part of curriculum committee, sometime, a couple of years ago, and also what they're thinking is, okay, we need the students treat and do more here and more cavities. They cannot graduate, and we have to control. They think our institution will prevent caries in the kingdom. That's not. This is a big. When I say King Salman Center, it has to contribute the whole kingdom in one place, plan and do something about it. It's not only one center or no. It has to be fluoride varnish. This is was for almost 40 years in Europe. U.S. never wants to use it. And 10 years ago, or about maybe 15 years ago, they started using it, and they were not approved as a prevention. It was a dentin-sensitizing agent. And later on, they found it's beautiful thing to use, and they started using it. So now we're still using. I'm not saying fluoride foam or gel is bad, but there is. We want to target the young age. The young age, we cannot use this, other things, fluoride varnish. So I didn't see any change for that.
No, really, my point very clear. I wish, and even Dr. Ali, I like him to comment that we have here in Saudi the behavior of general. I'm not talking about pediatrician. I'm talking about general dentists, interns, general dentists, how they behave toward prevention for the children. Every 5 years we can do a survey, then we publish it, then we can compare it with evidence base. Because I don't know, maybe there is, I'm not aware, but you draw my attention when you present, for example, Nebraska study. And I'm just thinking, I cannot call or recall a lot of these within our Saudi. So maybe Dr. Ali,
no, I totally
like comments in this on.
Yeah, I totally agree with you. We don't have in our curriculums that goes specifically for prevention and implemented in the curriculum. We're still teaching skills, teaching procedures. We are not teaching toward long strategical plan. And I think it is supposed to be an effort of the academician as well as a unified, as Prof mentioned, unified national plan with a certain vision for the Saudi kids. Other than this, we're going to hear this information and presentation next, even after 2030. Okay.
That's the problem, yeah.
So if there's no other comments, I'd like to, oh, sorry, Huda, Dr. Huda. Dr. Huda, sorry.
No, that's okay. I think what it is as we said just for the previous, there is no social responsibility in it. And we don't want to treat just the sick. We have, and the more impact is we treat to prevent, and this is public health. So I don't think the students are focusing on, they focus more on, as I say, expectation to be good clinical or clinicians rather than preventive and public health. So
we need to concentrate more on the knowledge and the prevention rather than skills, I think, in dentistry.
So as you
especially
said,
with the new technology that will take the skills away. So you need to stress on the, yes. So with this, I'd like to present the certificate of appreciation from the organization committee to provide.
So before I introduce the next speaker for this session, I'd like to welcome Prof. Abdullah Shammari, Dr. Salih Shamrani, Dr. Muhammad Al-Rafi, and other guests for joining us this session. Our third speaker for this session is Dr. Hilal Sambul. Dr. Hilal Sambul got his bachelor degree from King Abdulaziz University and got his master degree in cardiology from University of Gothenburg in Sweden. From the same university, he got his Doctor of Philosophy in cardiology. Currently, Dr. Hilal Sambul is Assistant Professor and Consultant in Restorative and Aesthetical Dentistry. He is the Chairman of Local Training Committee of Saudi Board in Restorative Dentistry Western Region, and he's a member at Dental Professional Council of Saudi Commission for Health Specialty. Today, he's going to present a topic entitled, Are We Treating Caries as a Disease? So please welcome with me Dr. Sambul.
First of all, thank you very much, Mr. Chairman, for the nice introduction. And indeed, it's a great honor to be here and to be invited by a prestigious society, the Saudi Dental Education Society, and by a very well respected educational institute, Riyadh Al-Almi University. So thank you very much for this opportunity. As you all have noticed, the title of this lecture is kind of a question. And for any question, we should have an answer, right? I'm pretty sure that most of the dentists all over the world, and probably also the dental students, know the answer. And they can say, yes, we are treating caries as a disease, but verbally. When it comes to reality, and when it comes to the way they believe in what they are doing in their clinical practice, unfortunately they don't. So we discussed this with Professor Lomeri yesterday about this dilemma. It's a kind of dilemma. I mean, people say things and they do something else. So I've tried my best to modify the lectures, to tackle it from a totally different perspective, and hopefully at the end of the lecture we can believe in the answer that we are treating caries as disease. Before I start, I would like you to watch this very short video clip, because I'm going to have some questions regarding it. I don't know about the sound or the voice. It's going to be... No need for the voice. You just focus on the guy.
It's 37% more powerful than standard paracetamol.
It's very obvious. It's kind of advertising for a Panadol, but it's. I just wanted you to focus on the guy or the engineer. It's very obvious that the engineer has or complaining or suffering from headache, right? So what he did is he took a Panadol and the headache just disappeared, right? So what do you think the reason behind the headache? Is it hypertension? Fatigue? Stressful work? Stressful field? It could be, shall I repeat it again? It doesn't matter. It's the heart. It could be the size of the heart is too small. So many reasons. The thing is, it's many reasons. But what actually Panadol did is relieves the sign and the symptom, and it didn't cure the disease behind it, right? It makes sense. So that brings us to the next slide. What is the definition of a disease? Simply dis-ease, lack of ease. And if we read the definition, a disorder or structure or function of a human animal, especially that one that produces specific symptoms, affects a specific location, and it's not simply a direct result of physical injury. So what does that mean? If we see a destruction or if we see a damage, that's not the disease. That's the sign or a symptom of a disease. So if we come to our hero here, dental caries, what is the sign and symptoms of dental caries? White spot, cavities, pain, probably broken tooth. And this is what we see in our clinic, right? When the patient comes, he or she has a cavity or he has a pain. So what we do is just start holding the handpiece and start drill and fill. So what actually we are doing is managing. Are we treating caries? No, we are managing the complications and the consequences of dental caries. We are just relieving the symptoms and the signs of dental caries, and we are treating the dental caries. Can you imagine that? If we have cavity, we just restore it, and the patient comes again, have a recurrent caries, and we replace the restoration again because of caries, and the patient goes in a cycle, restoration, re-restoration cycle, and at the end the pulp get affected, and the root canal treatment been done. Eventually, this tooth get lost. An implant or a bridge will be done for the patient. So it's a dilemma actually, and if we think of the root canal treatment, some of the dentists thought that if they have done a root canal treatment for the tooth, that means this tooth is in a safe zone. So I will pose another question. Do you think the root canal treated tooth is more susceptible to caries than the vital tooth, or the vice versa? It is. The root canal treated tooth is more susceptible to dental caries than the vital tooth. So ladies and gentlemen, please, when you take a decision to do a root canal treatment, it has to be based on a solid diagnosis. It has to be based on a solid diagnosis, not only for precautions or for preferences. So, as a result of that, we should look for a caries risk factors like plaque or biofilm. We should check or evaluate the plaque and biofilm of that patient, and we should look for the bacteria of that patient. And of course, these bacteria get multiplied by the diet, the sugar, the sweets that the patient, the sugar intake, the sugar attacks, and the frequency, the amount of the sugars. This is all should be evaluated. And of course, the saliva and the quality of saliva, the amount of saliva, and the buffer capacity of the saliva also should be evaluated. And when it comes to fluoride as a protection, it also has to be evaluated, like the oral hygiene, how many times the patient brush hair or his teeth with a fluoridated toothpaste. What is the concentrations? I always have this question, Doc, what is the best toothpaste that I should use? And when I ask dentists, what is the best concentration of fluoride in the toothpaste, they don't know. So on top of that, and make things very complicated, the time also is a factor. When we have patients wake up in the evening, eat a sweets and come back again and sleep, that's the worst scenario that we have. So I know that people here like clinical things. So if we have such a patient, I don't know if it's clear here, the radiolucency in the enamel. So these patients came 2016 with these lesions. So many dentists, I'm sure many dentists will make these teeth numb, and they start working on that and drill and fill. However, if you work on the risk factors that I have just mentioned and do the fluoride varnish and therapy, 2018 we have the same lesions with the same size. Nothing has changed. So just imagine you took a decision and you start drill and fill that filling. What would happen? Let's take another case. It's not only 2 years, it's 5 years. Since 2013, we have this radiolucency, and I'm following these patients. She is my patient. Till 2018, we still have the same size of the lesion. Why? Because I have addressed the risk factors. So people who think that we are talking theories or theoretical things, no, this is the evidence. This is the evidence. So let's move back to another things, and this is very important to be implemented in the curriculum, because people, most of our students, when it comes to advising or whatever in a patient, they said, Doc, this patient has a caries. We shouldn't say this patient has a caries. This patient has a caries lesions, because it's totally different. These are caries lesions. So we have to differentiate between caries lesion management and caries management. Caries management as a whole patient. And caries lesion management, we are talking then about the fillings and all that stuff. So controlling the symptoms of the disease at the tooth level, and here we are controlling the sign and symptoms of the disease as a patient as a whole. I'll always speak to my students, like when you excavate caries here, what you are excavating is a dead tissue. It's not caries. It is the complication of the caries. So let us move to another point. This question, would filling prevent caries? What do you think? Yes or no? No. But I want to make things more complicated for you, Doc, okay? What do you think? It doesn't. It doesn't. Good filling, it doesn't prevent caries. And we have a lot of evidence, tons of articles being published. Tons of articles. Most common reason of replacement and restoration is recurrent caries regarding to the quality of the restorations. However, the quality of the restoration play a major role to expedite or to make the progression more. So let us have this question about the risk factor. We know that the mutant streptococci is a risk factor to develop dental caries. So what would happen if we restored all cavitated lesions in a patient? What would happen for the mutants? Do you think it will disappear for good? It will decrease, right? But for how long? They have studied these two papers. There's a very classic literature regarding this issue. They have studied the mutants return back to the normal titer after almost 3 to 4 months. No matter was the quality of the fillings, it returns back. So at that time, what would happen? If the patients continue eating sugars or continue his lifestyle, so what would happen? Recurrent caries will occur again. And this is a study done here in Saudi Arabia. We have examined 803 restorations, and we did the caries risk assessment for the patients. We found that 56% of the restorations having recurrent caries. So when we plotted the percentage of recurrent caries per patient to the caries risk categories, we found that the higher is the risk, the higher is the recurrent caries lesions they have. Make sense? So, as a conclusion, if caries risk factors and the local factors has been overlooked or neglected, recurrent caries will be the end result. Let us move to the second point, or the third point, sorry. The consequence of placing restorations. Just imagine if you have white spots that doesn't need a filling, and you just numb the teeth and start drill these white spots to create a cavity and to place a filling afterward. What would be the sequelae or the consequences of this one? Of course, as we have mentioned earlier, the quality of the restoration is a factor, because not most of the dentists can do a very good class 2. Look at this. Another thing, restoration, no matter what it is, it has a lifespan. So one day, it will come to the end, and it needs to be replaced. So just imagine you took a decision to open a cavity that it doesn't need, and the patient can stay with that initial lesions or arrested caries for the rest of his life, and you put that tooth in a restoration, re-restoration cycle again. And this is a very important issue, to be honest. The patient comes to you with a primary caries, and you put him in another very difficult category that is called recurrent caries. Do you think recurrent caries is very easy to diagnose? It's very difficult. And I'm sure everyone in this room, when they look at the radiolucency under the fillings, and they started to remove the restoration, and they found at the end there is no caries. It's just like cervical burnout, I would say, or differences in the opacities. So it is very difficult to diagnose recurrent caries because of the location, the gingival wall. It is the most common. And of course, because of the radiopacity of the restoration and the radiographs. So again, just imagine you have open lesion that it doesn't need a filling. One more thing, and I think this is a very important issue. Do you think placing a restoration would increase the micro leakage or decrease the micro leakage? It's there. It's increased area of micro leakage. So let's have the story from the beginning. If we have a fissure, deep fissure, it is a kind of a line, right? So we have a micro leakage in that fissure, central fissure. So imagine that you have filled that fissure with a restoration. We transferred the line into a big circumference of micro leakage, and we're just focusing on the bonding, and we have to do a better bonding, and we have to do a better composite, and we are doing something really serious here. If we take a cross-section in that tooth, you will find that most of these are micro leakage. And believe me, till now we haven't reached to a perfect restorations. And I think many articles talking about the word permanent. We shouldn't use the word permanent filling or permanent restoration. It is all temporary. So all what I have mentioned earlier is from a dentist perspective. So if we come to the patient perspective, what do you think? We've done this study also here in Saudi Arabia. It's in the process of publication, and we asked many questions regarding knowledge, attitude, and behavior. And this is one of the questions that we have asked. Do you think your tooth will be decayed after placing a filling? What do you think was the responses? "72 said yes." No, sorry. 72 said no. And 28 said yes. But why do you think 28 said yes? Because they have it. They placed, because they have it. They've been through the experience. It's not their knowledge. بعد خرب مالطة زي ما بنقول احنا. So it is very serious also, I think, to incorporate or implement the health promotion in our curriculum. Health promotion standard in our curriculum is very important regarding dental caries. To wrap things up, I think I'm on time, right? And just leave some few minutes for questions. To wrap things up, this is a very famous depiction of the 5 senses of humans that we have by Gerard de la Serre in 1668. We as a human being, we have 5 senses: the hearing, the smelling, the sight, and this lady who's holding a bird for touch, and this is for taste, holding a fruit. So we as a dentist, we mainly use 2 senses, right? I don't think we smell in dentistry, but I think we use two senses, which is eye, we see things, and we touch. But we don't communicate with dental carers. We communicate with the patient. Now I'm just telling the same thing that Dr. Blahed has commented about the curriculum. We used to see discolorations in teeth, and we used to feel catch. I hate this word, catch. We are looking for a catch with a very sharp explorer. It doesn't make sense. Definitely it will catch, and wherever you put it, it will catch. It is sharp. So we follow, because of our human nature, we follow these 2 senses and ignoring the basic biology behind it. And I think part of it, because of our curriculum, in the preclinical, we have ILOs or objectives that is related to the biology, the pathology of dental caries. And then all of a sudden, when the students go to the 4th or 5th year, all of a sudden, these objectives change to another things, the psychomotors, how to do a perfect cavity, how to do bonding. They are not linked together. So the dentists or the students, when they graduated, they just follow their natures, the human natures, looking to the discoloration, the feeling, and ignoring the biology. So I think my presentations come to the end, and I'm very open for any question. Thank you very much.
Thank you so much, Dr. Sambul, for your informative presentation. And now we'll open the door for question and answer. Any question from the female side?
Assalamu alaikum, Doctor. Thanks for your presentation. I really enjoyed the the way you presented and simulating some of the thought. But Anna, when I starting your title, I thought you're going to talk about silver diamine fluoride. So, don't you think that we say are we treating the disease that we have other form that's...
I think it's a kind of trend nowadays using a silver nitride for it is something very beneficial, I guess. But I'm talking now about we have to start before caries to occur. That's what I meant. Yeah, so we need to work on it before it's there. Don't touch initial lesions. Don't touch white spot lesions. We have to think about the risk factors first. If we have cavitated lesion, then okay, fine. Then use silver nitrate, use fillings, use whatever. But I just wanted the new graduate or the new dental. I used to give this lectures or workshop for 2 or 3 days, and we gave it here in Riyadh Al-Ilm for the postgrad students. Their behavior and attitude have changed dramatically after these 2 or 3 days. So yes, I think silver nitrate is a good thing for a treatment, but I think we shouldn't wait till the cavity happened and then we use the silver nitrate.
Any more questions? No.
Okay, no, one more, only one. No, male side, to be fair. Dr. Hilal, I think we discussed this issue many times. Any dentist who practices now in Saudi Arabia, let us to limit ourselves, he or she is the product of the dental school factory, let us to call it like this. So any dental school to be recognized, it has a curriculum. And still, that curriculum must follow standardized things, you see. All of us, we believe, when we show the microscopic picture of that fissure going down, it's published by one of my colleagues, Jonathan Meyer. I remember this in microbiology and cardiology in Minnesota. He made a big issue at that time. But nobody changed, even in most of the dental school. Now, the legality point of view, when I try to follow the prevention, which is really, most of us believe in that, the sequential thing can be happen. Most of the key person in any ethical legal issue, they like to follow the traditional explanation for the expansion of that caries. So that dentist, if he or she practice away from the traditional curriculum in the certified legality practice, they consider this sometimes it's a malpractice. And he need to pay a price for that, you see. Plus, we don't like to ignore the politics of the industry.
The marketing.
I don't like to say it's industry things, you see. We need to follow, when I try to have a kit, with the first molar erupted, you need to seal it, okay? So when you like to seal it, you need to drill within the enamel. Yes, micro leakage can be increased, but no one of us can agree about that micro leakage will affect the healthy, sound enamel without exposing dentine down. So there is a lot of things. It will let us to continue dialoguing about this. So why this is introduction for you to answer me when we can close this gap, especially in the caries, because we are a country here, Saudi Arabia, suffering from the caries. Always we talk between 70 to 85% prevalence among our children. So how you think now from your own, because I am aware about all of your philosophy, the way how you talk to our graduate. By the way, to be clear, always we invite recognition for Dr. Hilal Sembel from Jeddah to travel to Riyadh every year to give his prevention, and how to treat caries in a proper way for our undergrad and grad, just to give them excellent Swedish-oriented, shot, we call it, among all of what we have, around us. But there is a problem. Do we continue with the vision, as Dr. Ali before we said, up to 2030, still fighting with this? What do you think?
I think it's a big problem, but if you want to talk about the solution, then we have to tackle many points. On dental school, what I've done, yeah. Okay, let me tell you what we have done in King Abdulaziz University. Well, the minute I arrived, I don't know because we don't have time, but the minute I arrived there, I was there as a teacher. I has no power. So what I used to do is just educate my students. And then I wait and started to make a lobby. I bring another teachers and try to put these theories in their minds. And then I became the chairman of the department. At that time, I started to use my authority and to change the curriculum. I start to implement dental caries as a disease. I start to implement the caries risk assessment, and we started to do a caries diagnosis. Now we have forms for as an MPE competency that the student cannot be graduated without an accurate diagnosis. It's not only discoloration, it's not only softness. There is biology behind it. And we have changed the objectives and the ILOs of our curriculum to be more toward prevention. And we are following our students since now we are applying this now for 4 or 5 years. So we have seen the change in their behavior. We have seen the change in their attitude regarding the diagnosis. Now, maybe we are waiting for another 2 years to publish a 7 years follow-up for our student regarding the caries diagnosis. But I'm talking about another level, which is the community. With community level, we have to have the public health now rule regarding prevention for the whole society. It's not only the educating our dentists. So we have another problem. We have patients. We have awareness. We have so many factors to address such a big issue, not only here in Saudi Arabia, it's also all over the world. I hope I have answered your questions.
Thank you so much, Dr. Sambul. Due to the limited time, we'd like to limit the questions. And I think it's a very critical issue. I'm pretty sure you will be around to answer any concern from other guests. On the behalf of the Scientific Committee, I'd like to present this certificate as an appreciation for your
Thank you, Dr. Hilal, for this nice presentation. And I think, as Prof. Shamiri said, that we have to change our line of product as academician toward oral specialist in medicine. Is not to graduate a dental physician, rather dental practitioners. Also, to know more about the malpractice, we would like to introduce our next speaker, is Dr. Jamal Assana. Dr. Jamal Assana is Dean of Postgraduate Studies at Riyadh Al-Ilm University. He has been the Director of the Postgraduate Orthodontics since 2009. He is an Associate Editor of the Saudi Journal of Oral Science and reviewer of many journals. And he is a head of the Institutional Review Board at Riyadh Al-Ilm University. He serves as many scientific advisory board in the kingdom and abroad. Dr. Jamal obtained his Master of the Science in Oral Science and Certificate of Orthodontics from the University of Illinois at Chicago, and he is a diplomate of the American Board of Orthodontics. Dr. Sana's topic today is an overview of dental malpractice in Saudi Arabia, and without overdue, please join me to welcome Dr. Jamal.
Thank you, Chairman. Dear guests, ladies and gentlemen, I'll take your mind off a little bit of cariology and talk about something that probably touches all of us in daily practice, yet it's often overlooked, whether in our curriculum or in our daily meetings, even professional meetings. And yes, I can say that we get a lot of lawsuits here in this part of the world compared to other countries. but it's interesting to just say that it's on the rise. And everyone needs to be well acquainted with this part of professional practice. Professor West talked on day one about what to do when you're in a dilemma and how you reach a sound ethical decision based on the problem at hand. Now, this is about the consequences of such decision sometimes. So, patient safety is freedom from accidental or preventable injuries produced by medical care. So practices or interventions that improve patient safety should be at the core of our daily practice. The extent of concern is not only affecting the patient or the practitioner, it also affects the regulator, it affects the medical environment, the hospital, relatives. And this extent becomes larger and larger the more the problem becomes unresolved and not addressed on a timely manner. So malpractice refers to professional negligence by a healthcare provider in which the treatment has caused harm, injury, or death of a patient. In most cases, malpractice is caused by a medical error, possibly during diagnosis, medication dosage, health management, treatment, or aftercare. There's a 7% claims rate or malpractice lawsuits in the States, about 5 to 10% depending on the source of study in Europe. Now, are all malpractices complications? Well, we need to make a differentiation between a malpractice and a complication. Complications arise due to unforeseen circumstances or outcomes when you have performed everything according to the standard of care. While malpractice are things related to patient negligence or lack of skill or poor communication and such. It is the duty of each and every practitioner to possess the knowledge of dental malpractice, its fundamental principles and responsibilities regarding the day-to-day dental care. The medical legal issues can involve direct or indirect contact with patients. If issues are detected early and resolved, there's a less chance of conflict with patients. However, if the issues cause serious harm or injury to the patient, civil and criminal disputes become unavoidable. I would talk about several experiences that I've had where I've seen an actual malpractice, not a complication, a malpractice is performed on a patient. Yet the patient is not willing to file a complaint. The patient starts thinking that this malpractice is not actually a malpractice, it was just a complication of treatment. The professional opinion says that that was malpractice. Yet, because of the good communication between that dentist and the patient is not willing to destroy that trustful communication or trustful relationship with his dentist by going to authorities and complaining. So, what constitutes a malpractice? There are 4 elements that needs to be present at those circumstances. Number 1, duty. There has to be a relationship of duty between the service provider and the receiver of that service. There has to be a breach of that duty. The physician would not perform the duty he is responsible for. There has to be an actual injury. Now, the definition of injury can change and can be variable, but it has to be a consequence of the failure itself. and an actual injury must be suffered by the patient. Proximate causation, that injury must have been caused by the doctor's malpractice. Not circumstances, but by the doctor's malpractice. So it has to be a causation relationship. So, malpractice in dentistry, it can take many shapes and forms, can present itself in many ways. Psychological, trauma to the patient's feelings or his well-being. Gastrointestinal, such as digestion, inhalation risks. Cardiac, whether due to anesthesia or stressful situations or a patient under medication without the necessary precautions. Cross-infection, very easy to understand. Allergies, accidents and mishaps. Treatment failure, damages because of negligence and lack of knowledge, lack of skill. General practitioner delivering highly specialized treatments, and this goes as well under the lack of skill. How does the doctor-patient relationship play a role? Well, according to data from the American Association of Orthodontists, lawsuits against orthodontists, 47% of those lawsuits were due to poor interaction between the orthodontist and the patient or the parent. 40% were due to a second orthodontist criticism, so another colleague criticizing someone else's work or another colleague's work. I don't know if we're all guilty of that. 6%, it was in retaliation of collection attempts or for financial reasons, and only 3% were due to poor treatment results. 3%. Most of the malpractice claims were due to lack of communication and someone criticizing another dentist's work. So the doctor-patient relationship is the pillar of success for clinical practice. The relationship entails numerous legal duties. There's a duty to trust, there's a duty of confidentiality, duty of care, and communication. There has to be rapport, empathy, genuine interest. You have to deliver your service with a smile. The patient needs to believe that you care for their well-being. So the ADA Code of Ethics, 2016, states that patient should have self-governance, the ability to decide for themselves. There has to be non-maleficence. You should not do harm to the patient. Beneficence, you should do good to the patient, put the patient interest as a priority, and his well-being and welfare. There has to be justice, fairness between patients. Something simple, I'm sure a lot of you didn't know about, giving patients discounts. There is some ground to the claim that if you give some of your patients a discount and not all your patients, those patients who did not receive that discount have some ground to sue you for malpractice. If you're going to give a discount, you should give all your patients a discount, because that could be constituting discrimination. Truthfulness. If a patient asks you for risks and benefit of a procedure, you shouldn't be skewed by financial reasons or unable to disclose the full risks and benefits of a procedure just because you like to use procedure A. You need to be truthful, and you need to explain those risks and benefits in detail to the patient and make sure he understood them. Helsinki Declaration. It is the duty of a physician to promote and safeguard the health of people. The physician's knowledge and conscience are dedicated to the fulfillment of this duty. It is a heavy task, a burden on us that needs to be taken seriously. The informed consent. We talk a lot about informed consents. How many of us actually take informed consents? This is the process of presentation, informing, and getting the acceptance of all aspects of the assumed treatment plan. Its implementation relevant to the person who voluntarily confirms his desire to accept it or not to accept it. So it's a statement of disclosure. Dr. Ali Abu Malik conducted a study in 2018, and he found that 33% of dentists surveyed in Riyadh neither never or rarely inform their patients about the risks of treatment before starting. We're talking about a third of patients being treated without a consent form. What is the medical legal status in Saudi Arabia? Are there any regulations in place to govern the relationship between a practitioner and a patient? Well, by royal decree in 1426, bylaws of healthcare practice, and it is there on the Ministry of Health website. This is the link. And this is the actual set of bylaws that govern the practice of medicine and dentistry and pharmacy within the Kingdom of Saudi Arabia. And every medical, dental, or healthcare provider need to be very well aware of those regulations. For the medical legal structure in Saudi Arabia, there are 22 medical boards throughout the country. They are called legal health boards, composed of a judge hired or assigned by the Ministry of Justice, a regulatory advisor who's an expert in those regulations, 2 physicians, a pharmacist and a faculty member from the College of Pharmacy in case the dispute includes pharmaceutical, and a secretary. Is there a difference between claims taking place at the private sector and the government sector? Yes, there's a difference. And in the private sector, all claims are directed to the Ministry of Health, which directs all those claims to the legal health boards at each region. While claims in the governmental hospitals are usually directed to internal morbidity and mortality committees that raise their reports to the director of the hospital or director of the region. Liabilities. What types of liabilities? Are they all financial? Are they all criminal? Well, there are 3 liabilities. You have civil liabilities, which are usually compensation related. Criminal liabilities, punishable by prison time and penalties. Disciplinary liabilities, which are also punishable by penalties. Now we come to the data. This information was cited numerous times throughout the process or throughout the duration of this conference. The total number of dentists registered in Saudi Arabia is 16,123 dentists, of which approximately 3,499 are Ministry of Health employees. And these are statistics from the Saudi Commission for Health Specialties in 2018. Does malpractice insurance cover you completely and comprehensively against those malpractice claims? Now we know as a requirement for renewal of your registration, you need to have a valid malpractice insurance. It can only cover civil liability claims. And that means you're not comprehensively covered. It can only cover you up to the amount not exceeding 1 million riyals, about $270,000. And if the alleged practice was within the legal framework of Saudi Arabia. It's very clear that insurance companies will only cover you if you're basically doing malpractice related to something that can be compensated financially. But if your negligence results in the patient's death, or if you're practicing without the proper documentation within the clinic or as yourself in terms of certification, or doing a procedure outside the scope of your specialty, insurance companies would not cover you. In a recent study by Abu Malik as well, only 79% of the dentists surveyed had active malpractice insurance. Is it needed? 20% don't have it. So the study looked at legal lawsuits and malpractice claims from 2009 to 2015. There were 724 complaints against dentists out of 5,993 total healthcare complaints. 168 complaints were at the city or the region of Riyadh. This is the distribution of specialties. So we could see that the highest number of malpractice claims were in the specialty of prosthodontics, followed by orthodontics, and then by far next the other specialties. Why prosthodontics? At least as well, why orthodontics? That wasn't much different than other countries. Sweden, Turkey, Iran all had the highest malpractice claims in prosthodontics. Reason being, well, we speculate that it's because of the cost of treatment, the complexity of treatment, and the patient's expectation. Prosthodontics usually is the last rehabilitation step in a dental treatment plan, and as a result, the patient would have the ultimate result achieved at that stage. So basically, in the beginning, the patient would have some emergency treatment, some periodontal treatment, even orthodontic treatment. But then, when they go for the prosthodontic treatment, this is it. This is the final stage of their treatment plan, and that's when their expectations are either met or not. What types of malpractice? Well, the study looked at different types, iatrogenic being the majority at 45%. You had no records. 22% of the claims had no records within the patient's file. Treatment performed by a non-specialist. Absolutely no documentation and no consent. Now, these are actual lawsuits that made it to the legal board. Not all lawsuits or not all claims submitted. There were delegations and there were discussions and actual hearings within those lawsuits. So there were results. Was there any difference between the genders in terms of who's more likely to file for a lawsuit? Well, in Sweden, females were more than males. Saudi Arabia, males and females were equal. We couldn't find an answer, but we speculated that because of the lack of legal counseling did not provide genders equal opportunity to deliver their complaints to the respected authority. Let's talk about something that we often overlook. Probably junior dentists attend a meeting, listen to a talk. That talk has a lot of new procedures, They feel enthusiastic about it, motivated. They go and apply it on their patients immediately. Now, in dental school, we teach evidence-based practice. Once the dentist graduates, we no longer overlook their daily practice. So there's a chance that when they attend what I call the infomercial lectures that companies support and speakers that are pushing for a certain technique or product because it financially supports them, the audience would feel more intrigued into exploring. And for them, a patient sometimes is their experimental field. So you had a high number of dentists willing to perform experimental procedures not proven by solid science on patients. 48% of the surveyed dentists would not perform any experimental procedures on patients. That leaves 52% willing to perform those procedures, not evidence-based, just because they listened to it on a lecture. And unfortunately, those lectures promote the notion of try it. Try it. The first time, second time, you're not going to perform it well, but then it will get better. You will get better. Your skill will become better. Now, even in research, doing experiments on humans is the last phase of conducting a clinical research. Usually you try it within a lab setting, then you go into an animal model, then you start doing randomized clinical trials. There is a clear violation of Article 27, Section 3 within the bylaws of healthcare practice in Saudi Arabia if you perform experimental procedures not proven by science. I don't think the 52 dentists who were surveyed knew about it. Now, refraining from treatment, I always hear that. I have the right to deny patient treatment. This is somehow true and false. Article 16 states that, except in emergency and critical situations, practitioner is allowed to refrain from delivering treatment, provided he presents acceptable personal or professional reasons, must though ensure that no harm to the patient shall result, and that there will be no interruption of treatment. It should not be based on discrimination, regardless of the reason, whether it was religion, race, color, gender. And acceptable reasons are not related to personal bias. Yet, 44% of the dentists surveyed would refrain from treating patients. So, what are the recommendations? If we know that most of those malpractice claims would result from lack of communication, the first thing we need to work on is our communication skills. That's why it is one very important aspect of dental education nowadays. Being able to establish rapport with a patient, being able to explain treatment thoroughly and explicitly, being able to address the fears of patients, understand their complaints, not asking them what is the problem, but asking them what is their needs, knowing more about the problem, being knowledgeable, and possible to deflate or to de-stress the environment in the clinic. If the patient comes to you, and I'm sure everybody, they have their bad days, you need to be able, or you need to have the skill to control that. You need to be a negotiator. You need to have the ability to listen, and I'd say to have certain etiquette to allow the patient to trust you. When the patient trusts you, this relationship will not be broken easily. And you'll be able to deliver your treatment with comfort, addressing complications with transparency, not feeling the burden of hiding complications when they happen. I know that junior dentists or students, sometimes when they have a mishap or when they have some sort of a faulty treatment result, they tend to hide it. They tend not to tell the patient out of fear of the consequences. If you have good communication with the patient, patients are usually very open to discussion and would understand that those things happen because of treatment complications, not because of your negligence. Also, risk management procedures within the clinic, regulations, certifications need to be updated. Safety protocols, patient safety manuals need to be in the clinics, and all staff members need to be trained on them. Infection control protocols and manuals need to be enforced. And documentation. Collecting the correct records, filing them correctly, and archiving them. If you tend not to write in the patient file clearly, this is grounds for a lawsuit if something wrong happens, because you cannot state that you've consented the patient or you've delivered the treatment needed without negligence. The fact that you did not write in the file is on its own negligence. Checklists. I'm a fan of checklists, and checklists help everyone use a systematic way into applying procedures within the clinic. So your staff members could be trained on checklists. New staff, new dentists, junior dentists should have checklists for how to address certain issues within the clinic. Just like frequently asked questions, or certain procedures should have a systematic way of transforming from the beginning of the appointment until the end of the appointment. I'd like to thank Riyadh Almi University Research Center for supporting that research. I'd like to really thank the Ministry of Health, Directorate of Health Services, for being very transparent with us, allowing us to access the records, to look into sensitive data, to be able to pass it on to you. I'd like to thank the principal investigator on this research, Dr. Ali Abu Malik, who's here attending, from the Ministry of Health, Dr. Amal Qadi from Riyadh Almi University for his assistance within this research project. And I'll open the floor for questions. I'll have 10 minutes for everybody, or 9 minutes if anybody has any question. And I'd like to thank you all. If anyone would like any information about this topic, they can email me, and this is my email. Thank you.
Thank you, Dr. Jamal, for such an important topic to be presented today. So we'll open for this questions or discussions. Yeah, Dr. Karen.
Excellent presentation. Thank you very much. I would like to bring up an area that I think you may see more in malpractice in your country, as we've just started to see it in the U.S. We became, I guess it's say we had a distinction of becoming the first school in the U.S. to have reused healing abutments, sterilized healing abutments, single-use items. And it has become a large issue across the country. Now, we all know that's equivocal, whether it makes any difference or not, as to whether they're single-use. But there's another large dental school in the U.S. that just had the same issue. So we're seeing this trend for the single-use items listed on the manufacturer's directions being sterilized and reused very routinely in a lot of different areas. And I guess I would just say that's something that you may want to do some research on in the future about malpractice cases, because it's at the forefront of what we're dealing with right now.
Thank you, Professor West, for the question. Now, I can tell you here in Saudi Arabia, using impression trays, plastic impression trays, that are not really marked as single-use impression trays, but if they're caught in the clinic being reused, this is ground for a penalty on the clinic. Yes, if they were sterilized and they were reused, because according to the regulations, only stainless steel or aluminum trays can be sterilized. Plastic trays are single-use and should not be reused on a patient. This is the current regulation here. I understand that caring for the environment, plastics, decomposing plastics and things like that would probably change the shift into reuse and recycling more and more. But until now here, single-use items or plastic items basically, because they're all usually plastic and they're used once and they could be sterilized, are banned from being reused in Saudi Arabia locally. For us to change regulations, it is, I can't say it's impossible, but it requires group effort. Probably can be led by universities or academic institutions, because those are the bodies of expertise relating to infection control, and it needs to come from them. Oh, that's impossible.
Okay. Well, believe it or not, we do.
Yes, they do. I'm aware of that. Correct.
Assalamu alaikum, Dr. Jamal. Very nice presentation. I just want to ask about the issue that you raised, which is the experimental procedures. And I'm just going to debate that, because how we define experimental procedure, how can you prevent that for innovations? And the case presentation, when you have doctors who have a new way of treatment or approach, and like the silver nitrate diamine that it has been, you can talk about it as a malpractice if you talk about experimental procedure, because something that they thought about it, or a procedure they do heart surgery but in a different way. How can you align that with what you said, that it is a taboo?
Okay, if we're talking about something that could be a device or a medication that could be approved by FDA, then FDA approval could be used as ground for something that is no longer experimental. But if we're talking about a modification of a technique, then this is not experimental procedures. Experimental procedures are something that is drastic, have not been tried before, and did not go through the process of a lab study, animal model, human study. Such things as certain surgeries, using certain implants that were not proven by science, and getting infection resulting from using those implants. I'm giving you a situation where a patient would have an implant procedure performed, ending up by losing his mandible. Things like that, because the practitioner attended a conference that told him that it's basically it's perfectly safe to use those implants in that situation. So I can't really give you exactly the clear distinction, but I would say if anyone or a practitioner is well acquainted of the bylaws and he can defend himself against those articles in terms of what his decision making was, then it should not be a problem, because it's a panel of peers that would actually look into the case. Yes, there's a judge, but you have physicians and you have practitioners who would look and argue, and he can provide evidence. But if you're unable to provide evidence to support what he is doing, we've seen lawsuits in the medical sector where certain incisions and certain suturing techniques were constituting malpractice because they were tried on a patient without going through the steps of normal sequence.
Any question from your side, Professor?
Thank you, Dean Jamal. Most of the topics covered this morning actually are well documented in booklets in the kingdom. When I teach ethics in research methodology, I try to ask the students, I say, how many of you are aware that there's a booklet on ethics issued by Saudi Commission of Health Practice, specialties? And surprisingly, many do not know that that booklet exists. Secondly, the derivative of the Declaration of Helsinki, which in 1439 here is documented as the laws guiding research on living creatures. Very detailed. And I think if our students, on their own or through teaching, if they are more conversant with these two documents, I think many of the things we are saying today will sink in better, because they do exist. They've been put together by some experts here, and I think our students should be aware that these documents are very useful to guide them in their practice. Thank you.
Thank you, Pope, and I agree totally. The Saudi Commission of Health Specialties has 8% of the weight of their examination directed towards ethics and patient safety. And unfortunately, they don't oversee undergraduate education, so probably undergraduates or bachelor degree students are not aware of the publications of the Saudi Commission. But maybe this is something we should introduce.
Okay, thank you. I think for the, we'll take the last one. Okay, we'll take the last one.
First of all, I would like to thank you for this great presentation, and you've tackled so many topics that more or less in the kingdom they're a bit of gray area. No one go through all these details that you just mentioned. Going back to the consent, and most of the practitioners in your survey says that they did not have any consent for the patients. From pediatric aspects, what is the age of consent for a child? I'm aware in the state is 16, and in the state is 18, and in the United Kingdom is 16. But what about Saudi Arabia? What is the age? And when you would say, I can treat a child without his parent?
In Saudi Arabia, you get your national ID at the age of 15. This is the legal age where you are considered an adult.
Mm-hmm.
So at the age of 15, once you have your national ID, that's it. You don't have or you don't need parental guidance. Yet, it is customary to have people use the term or use the age 18 as a cutoff point for guardianship. Consent forms in dentistry are sensitive because a lot of times teenagers come to the clinic without their parents. Yes. And not a lot of dentists refuse treatment. And it's an issue because a lot of times you need to have some written document coming from the parents that a procedure would be delivered to their kids, and you need to have the full disclosure of the risks and benefit of those procedures. So this is something I see in daily practice. That's correct. So it needs to be addressed, and parents need to be aware that they need to accompany their kids to all dental appointments. And ideally, dentists should refuse treatment if they are faced with those circumstances where there's no parents accompanying the child.
A quick one, not long. What about the assent form? Not the consent, which is the parent, but the assent from the child. This is
not common practice here, no.
Okay, so if you have further questions, we're going to have a break before the next presentation, so we can ask Dr. Jamal any question you want, and I'm sure that he will be happy to answer. So thank you, Dr. Jamal, again for your important topic, and on behalf of the organization and scientific committee, I would like to present this certificate of appreciation.
So we're going to have a coffee break for 15 minutes and they'll be back by 11 o'clock, inshallah. بسم الله الرحمن الرحيم والصلاة والسلام على سيد الأنبياء والمرسلين سيدنا محمد وعلى آله وصحبه أجمعين. Welcome back again to the first scientific session. I'm so glad to present the next speaker, my mentor, and I used to call him the father of endodontists, Prof. Saad al-Nazhan. Prof. Saad al-Nazhan has graduated from dental school in King Saud University, where he got his bachelor degree. He got his master degree of dental science and major in endodontics from University of Connecticut School of Dental Medicine. Currently, he's a professor in endodontics, Department of Restorative Dental Science, Riyadh University. Prof. Saad al-Nazhan is the editor-in-chief of Saudi Endodontical Journal, and he has several publications in national and international journal as well. His topic today is about root canal treatment, why and how. Please welcome with me Prof. Nazhan.
السلام عليكم ورحمة الله وبركاته. صباح الخير للجميع. It's my pleasure to be one of the speakers of this meeting, and the success that I can see through the media and through the people who attended this meeting. So thanks for inviting me to be one of the speakers. Okay, root canal treatments, why and how. I'm not going to say how you do it, because we all learn it in the school, okay? But I'm going to tell you how and why in my way. Okay. To start this, the definition of endodontics, okay, according to the American Association of Endodontics, it's a branch of dentistry that's concerned with what? With the morphology, physiology, and pathology of the human dental pulp and the periapical tissue. And also the clinical science include the what? The biology of the normal pulp, the etiology, diagnosis, and prevention of the, including the retreatment of the periapical diseases. So, what causes pulpal disease? There are several things that cause pulpal disease. And the major one is the caries, as we all know, followed by trauma, and then periodontal disease, developmental anomalies, and heterogeneity that we are creating during the operative procedure. The pulp is surrounded by well-organized structure called dentine, okay, and the whole pulp tissue lies there, okay, and laying on that structure. And this structure is not a solid structure, it's a hollow structure, okay. There's a lot of holes there called dentine tubules, and the average of the number of dentine tubules, believe it or not, is more than 30,000 dentine tubules per square millimeter. So, caries when it started, things will change. This nice organized structure become disturbed, starting from secreting dentine to close these tubules against this enemy, to the surface that has been become irregular in shape. The bacteria size is far, far small compared to the size of the dentine tubules. So this bacteria will colonize, multiply, and then invade the dental pulp through what? Through these tubules. So this is their highway to the dental pulp. Of course, the pulp will defend itself, as I said, by laying down dentine or neutralizing the acids and toxins of the bacteria through the dental tubules fluids. But to repair or to defend against a happy population of bacteria is really problems for that pulp. Okay, the pulp will start to respond through reversible pulpitis, irreversible pulpitis, and end with necrosis. So this necrosis means that the whole thing has been died. Patient need now help to remove this dead tissue and clean it up. So histologically you will see an empty space that has no more vital pulp or vital structures, and if you stain the dentine with Brown and Princeton, you will see a heavily population of these microorganisms inside these tubules. So how far this bacteria could travel to the pulp, the speed, okay, the depth, okay? It's been studied by Habisalo and Horswick in 1987, where they did evaluate the speed of depth of AV callus using a bovine teeth. They suction this teeth and took a dentist disc and inoculated this dentine with the bacteria suspension, okay, and then evaluate that bacteria using scanning electron microscope. And believe it, okay, in one day, they did remove the smear layer in this study. In one day, they could find that, this EV callus could travel up to 400 micrometers in these tubules. And when they extend their observation to 3 days, it's double. Okay? So this bacteria go into the pulp in speed, let's say. We did a study with a group of interns from Riyadh Al University back in 2014, okay, to study the penetration of bacteria. We selected 2 microbes, E. callus and Candida albicans, all right? And we did not remove the smear layer, okay, or we did not even use a vital or a normal tooth, okay? We did use retreated cases, okay, and instrumented cases, okay, teeth. And we found that, this Candida could travel inside the tubules, okay, based on what they found in the orifice of these tubules. And we measured these ones, and we found them, in different areas that it could reach even more than 55 micrometers. For the fecalus, okay, also they could penetrate the tubules, as I said there, and they could travel, okay, up to 55. So we conclude that, it depends on the nature of the service, morphology of the tubules, okay, and what they had, okay, of this bacteria could reach the root canal space. So if you take a culture of bacteria and you grow them, what are you going to see? Several number of species that has been identified. And believe it, it's more than 400 species of different types. Aerobic, anaerobic, gram-positive, gram-negative, okay? All of them has been identified. And still, there is a lot not yet been identified. The amazing thing that, this population of species, they work together as a team. Groups or single, okay? They secrete their acids, toxins, okay, gases, all right? And they are picked up by other bacteria. So this team work together. And they are destroying the pulp tissue, and when they go and reach the apical area, so during your root canal treatment, you should disturb this team, okay? Kick some of them out, others will die, all right? So try your best to do it right, okay, targeting them. So if this population confined in the root canal space, a microbial biofilm will be developed, all right? In the canal wall, ramifications, okay, isthmuses, even in the dentine tubules. So, not even that, okay? Through the early stages of the development of pulpal irritation, okay, and not yet even get necrosed, you will see some changes that occurred in the pulp, okay, including irritational dentine developments, internal resorption, okay, and when you reach the apical area, even some destruction of the integrity of the apical foramen, okay, plus the disease. So all of these changes, how can we clean them? Okay, you're not having a nice parallel walls there. So as an endodontist or dentist even, okay, you need to shape that one nicely, okay, to reach all areas. Area here is different than the area here, completely different. Okay, so the root canal treatment is a unique here, okay, and that we should depend not on the external factors like the patient's pain. Yes, it's part of the treatment, but you need to put some efforts as an endodontist to clean up and shape the skin and fill it later. So you shouldn't do it like a mechanics, okay? You need to do it in a biological way because you are dealing with bacteria and preapical tissue, okay? If any disturbance there, your outcome result will be jeopardized. Because here, the enemy, the bacteria, okay? So we need to eliminate this bacteria from the root canal space to have a good success. So our target or our achievement that we are trying to, by root canal treatment, is to grow from this picture, which has disease in the root canal space, necrotic and apical rarefaction diseases, okay, to a nice pictures of healing and restoration, okay? Or even sometimes when you have failure and this lesion confined to apical or furcation area, okay, to go to a nice healing, okay? Or even when you have a complicated cases like this one, endo-perio problems, okay, with the sinus tracts, okay, you need to do the treatment so you can have a healing, okay, and this is the target here, outcome result. So the treatment usually started with what? After diagnosis, okay, and placing your rubber dam, is with locating your apical constrictions, the apical foramen, correct? Nowadays we have the modern gadgets, okay, one of them is the electric apex locators, and their success to find the apical constriction is reach up to 95%, okay, so which is a good tool. Does it look like what you see in the radiograph, this root apex? No, it's completely different. What you see there is just a view, but when you go using your histopathological sections, okay, you will see that, the apex is not always to the radiographic apex, what you see there, okay? Anatomy is different than radiology in this case. Apex is not always to the end, okay? It's most of the time they are to the side, root. And this anatomy, okay, of the apex, if you highlight it, magnify it, what do you see there? Just remember these things, okay? Cementum, periodontal ligament, okay, and the dentine there inside the dental pulp. So our treatment is supposed to be to the dentocemental junction area. So these vital structures there should stay without disturbance, okay? طبعا don't forget the alveolar bone there. Cutler, 1955, in his study, which most of endodontists knows that he reported that the root apex, okay, or the foramen, sorry, is located at the apex in 26%, means the rest are not at the anatomic apex. They are off there, okay? They are to the side of the root apex, okay? And this average has been suggested to be 0.6 millimeter. Cutler conclude that, the root canal should be filled as far as 0.5 from the foramen because the average distance, as we said, 0.6. Sometimes you face resorption. So the cementum has gone. Okay? Everything disturbed there. So we have to consider that during the treatment. Or hypercementosis. Okay? Things lost. So I have to be also put that in mind. Reading your radiographs, understand the pathology of preapical diseases will help you a lot. Always you will find apical resorption in the root when you have persistent preapical lesions, minor or aggressive. Okay. Other applications, okay? The canal is not always straight. You will have some lateral canals at the apical area, or ramification if you call them. And if you see this picture, more root canal treatment. It's very complicated. Okay? How can I clean every ramification or lateral canals there? Is it important? Okay? If you do, excellent. But most of the time we don't. Okay. All right. This is a straight apical. What about lateral side? It's another problem. Okay? One of the things that's been advocated recently is the apical patency. And apical patency means that you're pushing your file, okay, whether small, sizes usually 8 or 10K, through the apical foramen. And the claim here by Buchanan, who advocated this thing, is that it will improve the irrigation, give better tactile feeling, okay, reduce the chance of procedural error, reduce transportation and pain. In teeth with necrotic pulp and preapical, the use of this patency file theoretically will favor the mechanical disturbance of the biofilm at the apical area. But injury to the preapical tissue, pushing debris, okay, and allowing even filling materials to go to the apical area is very high. All right? And then if it's happened, your outcome will be disturbed. A lot of people talked about it, okay, and one of them here that when the apical constriction is not violated, okay, by this patency, there will be no overfilling. Unfortunately, there is no clinical trial yet which specify this evaluation and the effect of the apical patency in the outcome of the root canal treatment. In animal studies, and one of them is Holland in 2005, okay, they found that, it has a detrimental effect on the outcome of the result of the preapical patency or using patency at the apical area. Between 1990 and 2010, three things thrown in the endodontic field, okay, and did some changes in the root canal treatment. Two technical, the use of nickel titanium files, and the magnification. In terms of biology, whether use or not to use intracanal medicaments, okay, especially calcium hydroxide. And the third one is the number of visits, okay, 1, 2, 3, okay. Endodontic rotary instruments, excellent, wonderful, okay, I use them, all right, it helps a lot, okay, at least reduce the fatigue, okay, البصمة على الأقل بقت يعني شوية لأنه في الجوازات دخلت في مشكلة في البصمة لأنه I have to use my left hand not right hand because I lost this through the years that I've been using a hand instrumentation. Excellent, okay. Do you know how many systems that you have in the market? 155 systems. Guys, come on. In the past with hand, we have only two companies, Cairn Premier, and then Mani. Okay? Now, everybody is selling these things. Okay? 155, and it's coming out more, I think. Okay? These things allows people to work fast, okay? And even in their advertisements, okay, they could finish the whole thing in less than half an hour in one visit. People start to discuss it, even in their forms. Is it really to finish root canal in 15 minutes? Yes, you have rotary, okay, one file, shoot, everything's gonna done. Because most of these rotary instruments, they've been designed to have only 1, 2, or 3, and those are, let's say, ashamed, they go to 5. Okay? Many of these papers, several papers has been even, what do you call it, published, okay, dealing with this nickel titaniums, and most of them are laboratory, okay, and let's say 90% of them, they deal with what? Instrument fatigue. And there's no clinical evidence, according to Spanberg, to show any improvement in the outcome of the treatment. Okay. Why? Because it's been abused, okay, by the practitioners. And a well done, or documented article by NAG, okay, in 2011, studying the prospective study about the factors affecting the outcome of root canal treatment and concerned with the periapical health. He concluded, or he observed that, the studies reviewing the outcome of endodontic treatment have not shown improvement, unfortunately. And some of them have also shown decrease in the rate of prognosis, okay, in the 90s and 2000s, compared to the old ones, 70s and 80s, unfortunately. Okay. Several studies also have shown that it's not unusual to have apical preparation to 0.35 to 40 millimeters. The design of the new instruments, okay, is confined to 0.20 and 25, unfortunately. Hand instruments, similar to rotary. You cannot clean the whole thing. You cannot clean the whole thing, okay? So you need some help from others, okay? The study shows that 10 to 50% of the canal walls cannot be removed or cannot be shaped by the rotary instruments. Hand, also the same thing. We did study with a group endo board, okay, and using scanning electron microscope to show the remnants of the debris that is accumulated in the root surface, the anterior root surface, okay, after instrumentation titanium files, and we found that, about, the score 2, because we have score levels, and cleaning and shaping. So compared to the control, you will see some debris, still there at the root surface. So we shouldn't be fooled with it, okay? Yes, I use it, as I said, but I use it in my own way, not the company way. Spanberg in 2010 reported what? An infected root, okay, the most important part of the preparation is the apical part, and this has been forgotten by this rotary instruments. So you need help, as I said, and one of the famous things, sodium hypochlorite, but we have to use it in what? In a good amount, okay? And you have to regularly exchange them so we can get the benefits of the antimicrobial activity. Calcium hydroxide, as I said, it's been dilemma, but still the best. And if you know the benefits of using calcium hydroxide, you will use it starting tonight, okay? Excellent alkaline, which going to change the environment of the acidity and inflammatory area of the root canal space, antimicrobial, excellent. And the things that has been forgetting and now it's been elaborated more is the calcium release by the calcium hydroxide, that it is what? It will pick up the carbon dioxide that is used by the anaerobic bacteria. Okay, it's plus, removing of the necrotic debris there. A lot of papers has been published regarding using calcium oxide. They reduce, eliminate, or decrease, and even sometimes killed the bacteria inside the root canal space. We did study back with one of my colleagues there at King Saud University using calcium hydroxide with chlorhexidine, and we found that, they are effective in controlling the fungi in the root canal space. Single visits, it will never give you benefits in terms of necrotic pulp with pre-apical. Okay, so you need more time based on Nair studies. Okay, at least necrotic pulp with pre-apical visits, at least using calcium hydroxide and control the infection. In a case, it has sinus tract, persistent pre-apical lesion, necrotic pulp of central incisor, being traced with the Garapercha, and with the use of calcium hydroxide and time, okay, you could see the success up to 13 years, okay, with no problems. Obturation level has to be according to the Cutler studies, okay, that the level has to be shorter than that we see radiographically, okay, and this is even superior than pushing things out. Okay, overfilling, okay, will reduce the outcome of the treatment. Overfilling, what will do, okay, it will allow the epithelial resistant malaise to proliferate in the area, and this will be, as I said, caused by disturbing of the apical area, and your lesion will be persisted there. Instead of healing in 6 months or 1 year, let's say, okay, it will take even more time, and sometimes it will not heal based on what sealer cement that you've been used. Langland and Nygaard, okay, all both in vital and necrotic pulp, they insist in leaving the apical area undisturbed. Case by Rikushi and Langland in 1998 through their study in International Endodontic Journal. They showed this case with apical persistent lesion, overfilling, lateral canal filled, okay, and when the patient come back after 6 years, okay, he has still persisting pain. They remove the apical part and they look at it histologically, and they could find, that, lesion is still there, okay, and inflammatory cells plus foreign bodies, okay, is being persisting in the area there that the body could not remove. Lateral canals, it causes a problem. I will be happy if anybody could teach me how to clean lateral canal with a file. No way, we cannot, no way, all right? So do we have to hustle with our root canal filling to push the filling to the lateral canals? Excellent if you do, but don't shoot it to the area where structures are there, okay? In this case, we see that, debris of the fragment of the sealer cement plus inflammatory cells in this root canal space. And you will see sometimes healing there. In this case, by Rikushi, Rikushi is going to come, by the way, to our meeting in the Endodontic Society in March, inshallah. You see that, this is a case which has apical rarefaction and lateral side, which is means that there is a lateral canal. Root canal has been done, and there is no material has been pushed there. Okay? So the follow-up healed both of them. Okay? So it's not necessary to push things there. Okay, yes, it's going to block it, but it's not necessarily. But you have to remember how to deal nicely with the canal during the root canal preparation. I'm always close to close. So they conclude from their study that, I can read it for you, because bacteria located in large ramifications might reach sufficient number of to cause or maintain diseases. Studies other than technique with sealers or Garapercha within ramification should be pursued to effectively disinfect these regions, okay, for optimizing the outcome treatment. I can conclude from this presentation that, endodontic treatment is a challenging, okay, and requires skills. Remember, we are not treating a root canal, we are treating a disease. So, biology, pathology are the foundation for successful diagnosis. Please allow me for Teacher Day is just to say thank you to those who taught me, Prof. Langland and Prof. Spamberg. Okay, I hope that I did, get some to tell you about what they told me. Thank you all.
Thank you so much, Prof. Nazhan, for your informative presentation. And I'm pretty sure if you give your time, will not be until the end of the day. But due to the time constraint, we'll not be able to receive any questions. And on the behalf, I'm pretty sure you will be around to answer any concern later on. In the behalf of the scientific committee, I'd like to present this certificate as an appreciation for your participation.
I'll be more than happy and honored to present or introduce the last not least speaker for this morning session. Is my colleague as an NYU alumni, Dr. Abdulaziz Abu Milha. Dr. Abdulaziz obtained his bachelor degree in dentistry from King Saud University, and he got his master degree of Master of Science in Biomaterial, College of Dentistry, NYU, New York University. And he obtained his international program in endodontics from the same university, as well as the postgrad program in endodontics from NYU. Dr. Milha is a diplomate of American Board of Endodontics, and he is currently assistant professor and vice dean for the clinical affair in College of Dentistry at King Khalid University, Abha, Saudi Arabia. Dr. Abu Milha's topic today is toward excellence in endodontics. Please join me to welcome Dr. Abu Milha.
Sabahkum Allah bil khair. It's a pleasure to be here today, and the more exciting for me that I'm speaking after my first endo teachers, Prof. Saad Nazhan, and also for my first operative, also by Dr. Abdullah Shemri. So the first obstacle I had before choosing this topic is because Prof. Saad Nazhan title was Endo, How and Why. So I don't know what I'm going to talk about after this topic, and Prof. Saad Nazhan. So I tried to be away, and I was concerned. I know he will go for microbiology. So analgesics and antibiotics in endodontics. Why this topic? It's not only for endo, it's for everyone. It's a concern. I will include also for Dr. Jamal Sani malpractice is prescription of antibiotics and analgesics for no reason. So for the completion also, for the endo, why we do endo? It's for two reasons. One, to remove and reduce. We cannot have 100%, as Prof. Saad, and you can see from the dental interviews. We're trying to reduce the bacteria. Second thing, we want to retain and to save the teeth. After all of that, we have a dilemma. And this is the big issue in the endo literature. We have two parts, success and survival. Success is like we don't have any sign of symptoms and we don't have lesions. Survival, we might have a lesion, but there is no sign of symptoms. We don't know how long this lesion had been going on, but we do it as a survival. Now, because of the literature is vague and wide, and most of the literature, you have to read methodology. The methodology is a problem that you cannot count on this article till you see it, the number of the sample. And you have to see who did these cases. Most of them are GPs, PGs. And this is also another problem because it's not like a specialist when we do it. So this also affects the outcome of the studies. Also the recall. If you have a sample of 300, it goes to a recall of 10% or 15%. You cannot count only on these studies. Going from this part, and this is the big issue that we have. In a school like this, you are taught on an evidence base. You are practicing with an experienced dentist. But when you go outside, this is the big issue. Can you hold this evidence base with the force of the patient requirement and with the need of the private economy? This is the ethical part. And this is where you have to keep your ethical and evidence base valid. You cannot go with the society and what is going to be prescribed with the patient. If the patient is usually taking antibiotics, you have always to inform the patient when he needs it and when he doesn't need it. Going from this point, starting the topic, which is a pain. This is a nightmare. The patient has the pain. And this is the shocking part. The pain is coming from where? It's a source of a tooth. It's not a source of his body. So we have to deal with the problem. Going from the problem that we have, starting from the bacteria, which Dr. Saad in his hands speak about it, is the bacterial source. Also, we can be the source by physically pushing the debris out. Chemical mediators that it's going also to cause the tissue damage. Now, for a lesion to happen, this is an inflammatory process. The infection is inside the root canal. You are treating the infection inside the root canal to help the body to resolve the inflammation at the lesion area. And this is what we call the pain and the swelling. Going from a simple way, if you try to prescribe this lesion, this is an inflammatory process. The infection is inside the root canal. We are treating the root canal and we are killing the bacteria inside it to resolve the inflammatory process. If you look to this lesion, what's happening inside, it's a dynamic. It's a big thing to go on. We're going from a mini destructive way to go for it. The bacteria is in the canal. What we have is the bacterial product, which is the body try to hold and inoculate in that area. And when you open it surgically, you will find all the tissue. It's not like a bone or anything. When you resolve and clean that area, which is the root canal, then you'll have the healing process. For a process point of view, when you do a root canal and we don't have any signs and symptoms, you cannot wait for the healing that will happen in 1, 2, or 3 weeks or 2 months. This size of a lesion, it takes a year and more. So you don't expect to have a healing in less than a year and 2 years. But also you can go for your prosthetic parts because you will help us to seal the coronal area and we have more higher success. When you talk about the analgesics from a point of view can help us as an endo, as a pre-treatment analgesics way in many ways. We can do like a pre-medications. If a patient comes with a pain, I can prescribe before the start of the treatment some analgesics. And we have a proof of the studies that we can have a pre-medication of ibuprofen 1 or 2 hours, then we start the treatment and we can go for a safe and a nice way in doing root canal. Also, it will reduce the flare-ups. Now, the thing which is not good about the prescription before, or the patient came to your clinic and he already have painkillers, analgesics, it might mask your diagnosis way. So if you're going for a percussion or a palpation, the patient will not give you the true, it will mask it. So if you want to do as a pre-treatment for a medication, it's before you start your treatment that you know already the diagnosis. Now when we go for the recommendation of analgesics, there is 2 tracks. First of all, you have to know the medical history of the patient. Cardiac patients, which we have a problem with many of their drugs, but mostly the warfarin. Warfarin is really the nightmare when you want to have the prescription, because most of the time it has an interaction with all the medications. So when we have a patient which is medically healthy, we go for a first choice, which is 200 to 400 milligram of ibuprofen. This is a mild pain. When we go for a moderate way, okay, we can have 400 to 600 milligrams, or we can make a combination. We call it the analgesic cocktail. So we have the acetaminophen and ibuprofen. Acetaminophen, which is the paracetamol. So we can have a combination. Then after that, we might have a severe pain, going for higher doses. Now the patient cannot tolerate the ibuprofen, we go for the paracetamol, or a pregnant. So we have to know the categories of the pregnancy, of the drug interaction. We have also the categories of A, B, C, and D. So the pregnancy, which also have, or can be a prescription of paracetamol, we can go from 600 to 500 to 1,000, or make a combination. Now, so the good combination for this in the market, which we can have it without a controlled drug, is the Solbadine. Solbadine, it has this combination with adding the caffeine, and that's part. So this is like a recommendation for you if you want to use it in your practice and how to have a good pain management. For antibiotics, big issue. First of all, what's the status? What we have right now? As a UK, they have that 10% of the prescription is by dentist. Now, this number is few, but don't be mislead because it's a higher number. Now, they made an advertisement to advise the people, take your need. And you can see here, keep antibiotics working. Now, what's the problem with this ad? It's for the patient. If I want to make something or switch in this ad, is to give it to the dentist or physicians, because they are the problem. The patient is not the problem. We are the one who give this patient. We are feeding him. We put it in his mind that you need antibiotics. Sometimes we don't have time. Sometimes we are in a hurry. We don't know how we can do the procedure. So we only give the prescription. So we can save the time, and the patient have something in his mind. So the patient already has his mind that the first aid is antibiotics, which is wrong, especially in the endo. You have a pulp and you have inflammatory, you can deal with it. This is the source. His body is nothing, okay? We have a tooth here which has a problem. The indication for the antibiotics. First, fever, malaise, lymphadenopathy, trismus, increased swelling, cellulitis, osteomyelitis, and a special category, which is the immunocompromised patient. If you look to the first to the seventh part, this is affecting the immune system. So the immune system is dropping. So you need something to lift it up, to boost it up. The immune-compromised patient is a disease way. Either it's acquired, or it's something that patient has a medication suppressing the immune system. So the cases which requiring the antibiotics: one, pain without sinus symptoms, symptomatic irreversible pulpitis, symptomatic apical periodontitis. Vital tissue has an immune system, so we don't need antibiotics for this purpose. Two, teeth with necrotic, pulps and radiolucency. It's not a sinus symptom that you can give antibiotics. Teeth with a sinus tract, chronic apical abscess, localized fluctuant swelling. These the diagnosis of the endo, and you can see the antibiotic requirement. Where we have it is the acute apical abscess with medically compromised patient, acute with symptomatic involvement, raise of the temperature, and we have a progressive infection that it be going on as a cellulitis. This is the only time that you can go with the antibiotics coverage. You cannot go with anything before. Still, your body is immune. Now, when we talk about the antibiotics and periapical lesion, does the antibiotics can go to the lesion? The answer is no, because we don't have a microcirculation. So if you think in that lesion, in that periapical area, has a vascularity that the antibiotics can go there, no. You just put your antibiotics, it will just always circulate in your body without reaching that area. So it's just a waste of drug, and it's like a malpractice in a way that you are giving an immune and a resistance for the antibiotics in that particular patient. So when you need it to be used for a coverage of a cellulitis, the body is immune now. So you have to go to a higher dose, or you might switch another type of antibiotics, or you might go for a hospitalization. So when we talk about the efficacy, how effective is the antibiotics. We have a nice study by Dr. Baumgartner. He chose the endobacteria, specifically the endobacteria, and he put it in a culture, and he brought the most used antibiotics in endo. We have the penicillin VK, which is very rare to use now, and this is the best antibiotics for the endo narrow spectrums because it has a narrow spectrum and it's specifically for gram-negative and endo. But because we have the first choice now is amoxicillin, it's become a weak way. So we cannot use it nowadays, but also it's a part of the study. We have the amoxicillin and we have the amoxicillin clavulanic acid, which is the Augmentin as a brand name, clindamycin for the penicillin allergic, and we have the claromycin, and we have the most lousiest, and this should not be used, honestly, is the metronidazole. If you look to the number of the bars, is how much each antibiotics have killed in that bacteria. So the penicillin VK, it killed about 85%. Amoxicillin is about 91%. The Augmentin, okay, 100%, kill all the bacteria because it's a broad spectrum. Clindamycin, about 96%. Clarithromycin is 89%. Metronidazole, 45%. And it has the most side effect for anything for our geriatric and everything of the patient and GIT. So when we go for the antibiotic duration, how much we keep using the antibiotics? You hear a lot about the complete course. Do you think it's right or wrong? Who said yes and who said no? Who will have 7 days as a complete course or 2-3 days to solve the problem? 7 days? Okay. Full course? Okay, I like interaction because it will make the debate very hot. Okay, so the full course. What we have, the endodontic infection is not rebounding. It's not like a medical part. Our infection is inside the root canal. It's not outside. So it doesn't rebound. So as long as you give the antibiotics, 2-3 days, I'm boosting the immune system to go back to its state of covering the area we have the inflammatory process. So when the body starts to going down with the swelling, you can stop using the antibiotics. Because what we have in the rest of the days, of the last 5 of the 7 days, is just abusing the drugs. It goes all your system. Now, when you can switch to another medications or another antibiotics, if you have 2 to 3 days, let's say you are using the amoxicillin, and the swelling is getting larger, then you can switch to a higher dose or a different generic. So then after that you can switch it. You cannot wait for 5-7 days. No. So the time is about 2 to 3 days where you can give the chance of the body to have the immune back. So the recommendation for the antibiotic, when we have it, first of all is the penicillin VK, but we cannot use it because our generation is really getting used to the amoxicillin. Penicillin VK is really now is not effective. So the amoxicillin, or with the amoxicillin clavulanic acid, which is the Augmentin, and clindamycin, claromycin. This is the recommendation doses. We can do a technique or a way how to have it is a loading dose, which we call a boosting dose. So the patient, you can give him the effective regimen as the first start. So you start with doubling the dose at the first dose, then after that you go with the regular dose. So this is a way how you can have the most or the maximum benefit from the first dose. Antibiotic exceptional cases or indication. This is an exception. So I have to try and give you all the antibiotics that when we use it in the endodontic condition. First, the immunocompressive. One is the leukemia, HIV, end-stage renal disease, uncontrolled diabetes, and we have the chemotherapy, radiation, and immunocompressive or suppressive post-transplant medications. So these medications are suppressing the immune system. So you have to have some adjunct with your treatment. Dental trauma. We have the tooth fracture, subluxation, extrusion. The only thing that you can add is for the avulsion. And they found the systemic is not effective as if you apply it as a topical. When you have the avulged teeth, to apply it as a topical, more effective than systemic. Cardiac patient, this is the only recommended case nowadays to give the antibiotics prophylaxis. When you have the prosthetic card valve, previous infective carditis, congenital heart disease, and cardiac transplant. Rheumatic fevers, bypass, all of this one is not recommended anymore. Now for the record, just because always the idea that endo is producing bacteremia, producing bacteria. When you have to see the literature, you'll be shocked that there is simple things that you might have in your practice inducing bacteria than the endo. This chart from this nice study, tooth extraction can be from 10% to 100%. Periodontal surgery, 36% to 88%. Prophylaxis, up to 40%. Rubber dam, yes, it can have 9%. Wedge placement, surprisingly, it can have 32%. The poor endo people, okay, are only up to 20%. Can you imagine your wedge is more producing bacteremia than the endo, which comes to a way of thinking that the periapical area doesn't have a microcirculation that you are pushing out. When you have the area of the periodontal area, it's really fully of vascular blood that you can have it. So all the procedure can have it. It's not like endos always have the touch of the vessels that you can have the bacteria on. The last thing, which is the joint replacement and hip replacement. It's not recommended anymore to have any antibiotics prophylaxis. The last message, this is really what's happening. You have the tooth and you have the spoon of the medications. We have a problem with the tooth. We don't have a problem with the patient body. The problem, we're always thinking about the tooth, but we always forget there is a human being attached to that tooth, which is the opposite direction, okay? So when you do your procedure, you really seldomly would need even analgesics, antibiotics. If you think of biological way, as Dr. Nazhan said, then your problem is less. If you do know how to clean and shape, how to remove the bacteria, how to deal with the post-operative pain, you will not need this prescription. Second advice, nowadays you have the iPhone, smartphones, you have the applications. You know exactly all the interactions that you have between the drugs. You can do it. There is no any choices for you nowadays or any like excuses for you that you don't know. You have it and you should know it. You will wait the physician to give you the advice, but also you have to make sure of that advice. You will be more concerned about your patient and your practice. Thank you very much.
Thank you, Dr. Abdulaziz, for such an important topic to be presented today. And we're going to open for questions. Dr. Huda?
I know you will talk.
Yes.
I'm just going to address, there is the opioid epidemic in the United States, and they find out that, one of the main cause of that epidemic is that the over prescriptions of use from the dentist. And how can you that one with your...
True, that's true. Thank you very much. I try to be more specific and give exactly the information they need, so I will not be getting wider with the statistic, but the statistic is really big. I can see so many of the poster here had been done in different schools. It's happening here. It's almost the same, even worse, the way how they prescribe the antibiotics and analgesics.
We have another question here.
I tried.
Assalamu alaikum, doctor.
Walaikum
Thank
salam.
you so much for a very nice presentation. My name is Dr. Johria, and I'm an associate professor at Princess Noora University. I have one comment followed by one question from you. My comment is regarding the applications of the prescription of antibiotics wherever it is indicated. Usually the new recommendation of the International Society of Infectious Diseases is that you do not give it for less than 5 days. Because if you give it for less than 5 days, less than the prescribed and the recommended dosage of the antibiotic, that sort of increases the chances of the patient developing antimicrobial resistance, the antibiotic resistance. It enhances that. So for the 2 or the 3 day doses, now they have taken those out of the treatment regimes, and most of the treatment regimes now have at least 5 days to 7 days, dosage recommendations. The question is, have you any experience regarding the laser and their antibacterial abilities or functionality in terms of endodontic treatment, like the laser-assisted endodontist?
Okay.
Thank
So regarding the first question, the problem with the endo, we are not dealing really with an infection. Okay, it's an inflammatory process to an infection inside the tooth. So if you're going to use antibiotics, that means to go to the infection area. We don't have a circulation. That's the idea. You're talking about the medical way.
Yes, I said only where it is indicated. Now for the normal pulpitis, and it's not indicated, so not in those cases,
Okay.
but for cellulitis and all.
Exactly, which is the body immune goes down. For the laser, there is many studies. It's not really reaching to the level nowadays that can remove, because the intensity to go inside the canal, and especially with the narrow canals, and when they have a curvature, it's not effective. For an endo part, most of the bacteria is going to the apical part, okay, the last 3 millimeters. As these studies, they are done outside. It's not inside to see really how the real life going on. So it's not effective so far to have it. Maybe in the future, if they have some instruments or modules that can go to the apical area, yes.
Thank you so much for
Most
a very
welcome.
nice presentation.
Thank you.
Any more questions? With this, we'd like to thank you again, Dr. Abdulaziz, and on behalf of the organization and scientific committee, we would like to present you the certificate of appreciation.
So on behalf of the Scientific Organization Committee, we would like to present certification of appreciation for our chairperson, Prof. Hanan Balto and Dr. Ali Al-Hadib. So now we'll have a lunch break, and we will resume with our scientific programs at 1 p.m. Thank you. Oh, you want to?